and was awarded the Morris Collin Award for Excellence last year, which is the highest award in medical informatics. He has innumerable publications, including one of the most widely used informatics textbooks. He's also won numerous awards. He earned his PhD. After his MD, he earned his PhD at Columbia University, staying on his faculty for years, and became prominent for his work in clinical informatics, including in terminologies, buttons. He then joined the NIH to help further the use of patient data, and he's currently is continuing in this mission at UAB. He will present a very timely topic that is on everybody's minds now, not coronavirus, but that's part of it too. Is biomedical informatics abetting systemic racism? I'd like to find out.
Hey, thank you, Amy. Welcome. Thanks for joining us on this morning. I'm sure everybody else out there like me has a lot of competing things. I want to talk to you about this idea that biomedical informatics is not devoid of racism, and it is not something that we should be thinking about when we all are thinking about eliminating racism. I gotta make sure this thing is going to click for me. Let's see. There we go. All right. So of course, current events. It's been quite a year. And we started this year with all the things that we always have. So for instance, climate change, we started that with climate change, but late last year, we started to see cases of new disease that actually got its name on February 11th of this year, COVID-19. Can anybody remember when we didn't know this word and it wasn't that long ago? And so this has really dominated a lot of things and it's influenced a lot of things. So for instance, climate change, it's now very difficult to maintain social distance when you're busy fleeing various environmental challenges. And so whether it's hurricanes or fires, and another thing that we've had around with us for hundreds of years, racism, and anti-racism has emerged as a stronger force in more recent years. And for a number of reasons, it has really emerged in 2020. And so, I'm not going to talk about my own personal journey and such, but I do want to talk about what I'm trying to do about it. Now, before we start, I want to talk about I want to provide some definitions so we're all on the same page. Racism, prejudice, discrimination, or antagonism directed against a person or people based on membership of a race or ethnic group. Racial discrimination, which is part of racism, is the unjust or prejudicial treatment of a category of people or things based on race and ethnicity. Now, racial disparity is a difference associated with race or ethnicity. So it may be in prevalence or outcome of something. It is not necessarily due to racial discrimination. So for instance, there's a racial disparity in sickle cell disease. That's not due to racism. However, when we see racial disparity, we have to wonder, is it due to some sort of racist activity? Now, another thing that's important to think about is implicit or unconscious bias. This is bias that operates outside of a person's awareness. We all have it. It's how we get through the day. And what's interesting about it is that it can be in direct contradiction of a person's espoused beliefs or values. So you may have implicit biases about, for instance, characteristics of somebody in a certain race. And while consciously, if somebody asks you, do you believe this? You might say no, or it doesn't affect me. Unconsciously it may. Systemic or systematic racism, and people do distinguish between these terms. I'm not going to distinguish between them here. And this is racism or racial practice that's embedded as normal practice within a society or an organization. And an organization can include a computer system. Non-racism is something I hope we are all trying to espouse, and that is the quality of not being racist. But anti-racism is actively opposing racism and promoting racial tolerance. So it's not just saying, I don't do anything racist. I'm not hating anybody. I'm not hurting anybody. I'm going about my life. Anti-racism is the recognition that racism is going on around us all the time, and that our our complacency is perpetuating, and we need to be active in opposing it. Okay, so I thought I want to be anti-racist. So what can I do? Well, I'm one person. I can vote. I could donate. If I was a billionaire, I could donate a lot. Maybe that'd make a difference. But the reality is I'm not going to make that much difference by donating. I can go and march and add my presence and my voice to protests. So that's something I can do, something we can all do at a personal level. But, you know, that's one person. So I wanted to figure out how can I amplify my effect beyond that. So I have a professional role. I'm the director of the Informatics Institute. So one of the things I can do is I can look at how we hire and train people in informatics within our own institution. And my colleagues and I in the Informatics Institute, I think, have done a pretty good job building a diverse group. All right, so that's now maybe extended out to a smaller circle around us. But then I thought, what about other things I can do? And I have professional influence. So as a researcher, I publish in prominent journals. And so perhaps I can get a voice there. And I actually just submitted a paper to Jamia that presents some of the information that I'm going to present in this talk. And maybe that will bring some national spotlight on the problem. And I also have national prominence in the field. People listen to me, and I have a bully pulpit then to get up and talk about this. So that's professional influence. But even better than that is that I'm an informatics researcher. And so I do things like build computer systems. And those systems aren't just for me. They can go out and help a lot of people. And I publish the research so that other people can replicate what I do, and that can go out and influence other people. And so I hope, for instance, that my creation of info buttons, which I hope are not being used in a racist way and are out there helping people of all races and ethnicities. So I said, okay, how can I direct my research towards anti-racism? Okay, so what do we do? Well, first of all, we got to figure out what's out there, what are the problems that we need to fix. So I'm going to look at a number of areas now of problems in related to data information systems where racism can or does play a role either unconsciously or consciously. So it's a bit of a collection of things. So our conscious discriminations, I would ask somebody to watch the waiting room because it keeps jumping up on my screen and it's a little distracting. So somebody please watch the waiting room, even though I know you're riveted to my every word. So conscious discrimination with information systems. Of course, we can subvert any system to help us do bad things. And so there was this article in The Guardian. If I can get my mouse working again. Article in The Guardian about a company named Palantir filed to go public. And they said the firm's unethical technology should horrify us. So what is this unethical technology? So they have a data visualization software, and it's a longer story, but the short answer is that immigrations and customs enforcement agents use Palantir's software to target people immigrants, and use it to separate family members and sponsors of unaccompanied children and other undocumented people entering the U.S. So it's been used for a purpose that promotes a racist policy. And so the rise of Palantir is a dangerous development. They said in the United States, its tools have mostly been deployed against immigrants and Black communities. Now, I don't know who all the customers of Palantir are. I actually think it's unlikely that it's really just been focused on this. And I also don't think that the software itself has racist attributes. I don't think there's a racist button in there somewhere, but it can be used that way. And we have to think about how people are using those tools, because we may detect disparities in the use of tools like this. And there is a connection to biomedical informatics. It's just perhaps coincidental, maybe not. But the National COVID Cohort Collaboration, or NC3, at the National Center for Advancing Translational Sciences, or NCATS, is using Palantir as the database for data on NC3 or COVID-19 patients. So I don't think there's anything sinister going on. I'm not actually worried about this, but the potential is there for somebody to use tools like this for racist purposes, and now we're putting patient data in there, and especially vulnerable patients. Okay, what about implicit disparities of the distribution of health resources? You know, we hear about this all the time. about how some communities get more health funding than others. And there was a study last month in JAMA on the allocation of COVID-19 relief funding to different counties, and it was disproportionate. And the reason that it was disproportionate is the relief funding was tied to revenue of the hospitals, not based on health or financial needs of the population. So, Beverly Hills hospitals, maybe they got a lot more because they have higher revenues. And the rationale was hospitals that have higher revenues have higher expenses and are caring for more people. And so they're going to need more money. But this actually meant that Black communities were receiving the same level of funding as other communities that had less health and financial need than they did. And that this has a disparate impact on Black populations, even if they don't directly use race as a decision factor. They're using a proxy for this. And so when we see disparities in health resource allocation, think about where that's coming from. And it's particularly important for this case of COVID-19 because it turns out that patients with COVID-19, that Blacks have a 3.57% higher relative risk of death compared to whites. So you would expect them to have higher financial and health needs, not equal and certainly not lower. All right, now disparities with health information systems. So when we see in the health information system working and we see some kind of disparity in how it's performing, again, a place to look at. Now here's one that's interesting. JAMIA last month published a paper on the use of telehealth. It was self-reported information. And it reported Black respondents were most likely to report using telehealth because of the pandemic. So there's been an increase of telehealth use by a lot of people. Blacks over whites reported use of telehealth because related to pandemic. The conclusion in that paper was that systemic racism creating healthcare disparities has raised the need for telehealth. So there's actually more need for telehealth because of racism. Findings suggest opportunities to leverage a broadly defined set of telehealth tools to reduce healthcare disparities post-pandemic. So there's a lot of interesting things in this paper, but one thing to consider is if Black patients are using telehealth more because, for instance, they're more afraid of getting COVID-19 because of that increased mortality rate, are they getting the same quality care? Maybe now there's going to be a disparity, for instance, in flu vaccinations because people are using telehealth and not able to cover for flu vaccine. Or maybe telehealth visits just aren't as complete because you're not seeing the doctor in person or what have you. So these are disparities that we need to pay attention to. It may be that this is a good thing, but it may be that there are some unfortunate unintended consequences as well. All right, so I talked about implicit or unconscious bias. We all have biases in our decisions, and there are association tests that can uncover these biases. And there's one set, you can use these to measure your biases about racial relations. There's a set of these tests that you can take. It's like playing a game. They show you, they tell you to push a button one way or another way, depending on some, it could be on race, it could be on some other quality. They show you some text and you have to respond as quickly as possible. And while it is a game, I can tell you that, and it doesn't take long and it's not hard to do, it is not fun to find out that you suddenly do have these biases that you did not realize that would affect things like your response time to a question about, do you think this is a good person, or do you associate the word good or bad with somebody of a certain race, that sort of thing. So I recommend you go out there and look for these. They are worth doing, but do them anonymously in a closed room by yourself so nobody else can see what you're going to learn about yourself. Okay, implicit bias, machine learning. Well, machines don't think. They shouldn't have implicit bias. And the people that build them don't build them with the idea that they're going to be used in a discriminatory manner. We don't set certain nodes in a neural network and say do this if it's one race or do that with another race. At least I hope we don't. So how does implicit bias get there? It gets in there because machine learning learns from what? What does it learn from? It learns from data. And the data may come to us in a biased way. And if those data are biased, then they're going to bias the machine learning algorithm. So this paper in Science, I think it was last year, was looking at racial bias in an algorithm used to manage health populations. And so there was this widely used commercial algorithm that assigned sicker Black patients to the same level of risk as healthier white patients. And the reason it did is because it was using data that, well, I'll come to that in a second, but the effect was that it reduced by half the number of Black patients who were identified for extra care. So in deciding who needs care, white person, Black person, it was giving it less to the Black people. The reason was, again, it comes to this idea of health expenditures. It was using health costs as a proxy for health needs. Less money is spent on Black patients with the same level of need in poorer communities. So you go to a community where there's less resources and a larger Black population, those resources are going to be, used per person at a lower rate than at a wealthier, with a higher prevalence of white patients. And so the conclusion was that Black patients are healthier, and that affected that machine learning algorithm. So this is a real problem. Natural language processing. Here's another thing where we think, oh, well, it's just grammars and rules and association. No, but it's a machine learning algorithm. And again, what we put into it is going to affect what comes out of it. So this was a monograph from Oxford Insights on racial bias in natural language processing, and they looked at a number of effects. A lot of what they were looking at was around the idea of word embeddings, which is a technique that looks at frequently co-occurring words to infer the meaning of the text. And these embeddings then can pick up stereotypes and prejudices that will actually be in the text. Offensive language and hate speech is often included in the text that gets used. And it doesn't deal well with linguistic variation. So you may have different patterns of speech, different colloquialisms, things that are used in different social communities that will cause the NLP to behave in a racially disparate behavior. That is, for example, if it's reading something written by a Black person, it might interpret it differently than something written by a white person, and the outcomes of whatever that NLP is being used for will be affected by that. And this can perpetuate biases. Okay, so another one is guidelines. So, guidelines are, let me just say a word about guidelines. So guidelines are something where that we create using hopefully best evidence to get people to practice whatever, healthcare or whatever, in the best possible way. And so we build these guidelines with the evidence that we collect. And the question is, does implicit bias either creep into the guideline or affect how people use a guideline? So there are false beliefs about racial differences in pain perception. These have been well studied. There's beliefs that Black patients can tolerate pain better than white patients, that Black patients have thicker skin than white patients, things like that, that could lead to disparities in assessing and treating patients. And so in the Proceedings of the National Academy of Sciences, they looked at people's beliefs in these things in pain assessment and found that, in fact, relevant biases do exist in how people would handle guidelines. Now, there was one study done of for dental patients getting preoperative, postoperative pain medication for dental procedures, and was looking specifically at that. And I'm very happy to say that it found really differences based on insurance coverage, but no independent effect on race. So if you look just at race, of course, you would see a disparity. But when they looked at the underlying cause, they found that actually when you control for insurance coverage, there was no difference. And I say I'm glad to see that for two reasons. One, because I'm glad to see that people are, not using race in deciding who gets pain medication. And the other is because it was done by Michelle Robinson here at UAB and her colleagues. So it's nice to see that we're in the forefront. Okay. I can't read the title here. Conscious bias in clinical guidance. So, do we ever write guidelines that discriminate or behave differently because of patient's race in a deliberate manner? And the answer is yes, we do. So this is a recent article in New England Journal of Medicine, Hidden in Plain Sight, reconsidering the use of race correction in clinical algorithms. And you go, race correction, why would anybody do that? Well, it turns out that glomerular filtration rate estimates, there are formulas for this, and they're they often include the race of the patient as part of the calculation. So they use creatinine, they use age, some of them use weight. But the most popular one uses age, gender, creatinine, and race. And if you are Black, you get a 21% higher GFR estimate. And this is based on a number of studies that seem to be relevant, but the question is whether that GFR is clinically different than somebody with a different calculation. And what the question they raise is that using race as a correction can ensure, by removing that, we can ensure our clinical practices don't perpetuate the inequities that we aim to repair. Meaning, you might not refer a Black patient for specialty care because, oh, his GFR is, it's a little higher than the other one, so we're okay. And so it's they have a number of different types of guidelines that they look at in that article. A very interesting article to see where race is used in these guidelines. Okay, so computerizing guidelines. So now let's think about this. We talk about guidelines being kind of an informatics process. It uses information. It doesn't always involve computers. But where it does use computers are alerts and reminders. So what are alerts and reminders? These are logic that's added to electronic health records to apply guidelines to care. And you typically see them in the form of alerts and reminders. And they do things like remind you about healthcare maintenance. So a patient comes in for a visit. Hey, doc, this patient needs a flu shot. They can also be alerts to things that you order or other things that occur. So for instance, you're going to order a drug and the patient has an interaction with that drug. You're going to order a drug, the patient has an allergy to that drug. You might overuse a resource, or you might give an inappropriate medication dosing. And they look kind of like this. So here's one. You're attempting to order CT abdomen contrast, but the patient's GFR is 25. So consult with nephrology before you do this. So I wanted to order a CT CAT scan of the abdomen with contrast dye, which has iodine, which affects the kidney. And this patient has a GFR of 25. So there's that GFR thing. Now what do I do? Well, I can agree with this alert. I cancel the abdomen CT and I say okay. So then I've agreed with the alert, or I can override the alert. Some alerts allow overrides. And so if I override this alert, then I'll have to pick a reason from a list of reasons why I want to override. So those are the alerts. So what it got me, and here's the GFR calculation. So this is actually used in the alerts at UAB. One of the alerts isn't triggered itself. Other alerts trigger and say, hey, what's this person's GFR? And it uses the patient's race, as you can see at the bottom there, and will increase the GFR by 21% if the patient's Black. So we do actually have that, and this is accepted practice. It's considered to be a good thing, but we have it here. All right. So this got me. I thought about this, and I said, okay. So if I want to look at a system and see if it's behaving in a racially disparate way, I could look at the override rates. And if I see that override rates are higher for these alerts where there's a race-based GFR calculation, or lower, I could say, hey, maybe there's a disparity here that we should look into. I'd also like to look at override rates for alerts related to opiate use. If a system, you could imagine that if somebody says, well, I believe that Blacks have a higher pain tolerance than whites, and the alert says, hey, that opiate dose is too high. If the patient's Black, they go, oh, okay, sorry, I won't order it. If the patient's white, they may go, yeah, I think this patient has a lower pain tolerance and is going to need more, so I'm going to override the alert. So that would be an example where you might override an alert in favor of a white patient, or towards a white patient. I wouldn't say in favor, since maybe it's not so good to do it. But the point is that there would be a racial disparity. So I want to look at those. And then where there's disparities in any of the alerts, I can look at the reasons given for override and see if people are tending to use one reason over another that might suggest that they're using racial biases in making their decisions. So that said, here's my little study. And this is a great study. These are great kind of study you can do while you're sitting on a boring conference call on Zoom because nobody can see what you're doing. Maybe one of you are doing this now. You go to I2B2, you download a bunch of data, and you analyze it. This data, I needed the help of Amy Miles from the Institute to get the data for me, because alert data are not in I2B2, but the idea is you get these de-identified data sets and you can process them really easily and answer questions. So what did I do? I got all the alerts from UAB Hospital for 2019. I removed small racial classes because I wanted really to focus on Black patients, white patients, and all the others, at least at UAB, they're very small, as you'll see. I also excluded the events for overrides that are not overridable. That, there's nothing that the physician or nurse can do with that alert, so we excluded those. And then I looked at the override rates, actual override rate and expected override rate. If I said, okay, well, the index was, let's say, is white patients, what's happening with the override with Black patients? And then I looked at easy reasons for overrides. So sit tight. We've got a lot of data to look at. Hopefully I can make it clear. And this hopefully is going to come out in JMIA if it gets accepted, and we'll have all the detail. And I'm happy to share these slides as well. Okay, so here are the different races, and we can see the total number of alerts, and the big groups, white and Black or African American, and the other groups much smaller. Hispanic and Latino is the next smallest group. Then we've got decline or refuse, which, as far as I know, is not a racial group, although maybe there is a refuse mix as a racial group. I don't know. The others, and then the others are all much tighter. So they were excluded. There's a total of about 4.5% or so that were excluded. So let's look at these big ones. Whoops, where are we? We'll carry on. Okay. Huh? Sit still. I don't know what it's doing. It seems to want to take this away from me. But anyway, as you can see, let's see, I'm going to pull out of the, oh no, okay. Because of the way I'm sharing, I can't do it. The rates are very small. And 81%. This is going to just, here we go. All right, thank you, Microsoft PowerPoint. Okay, so there are 169 types of alerts. 5 million occurred 5 million times. When we remove the alerts that don't allow overrides, there were 35 types of overrides that were triggered almost 1 million times. And so we can see, and then when we look at just Black or white or American, we can see it was 900,000 times. So 37,000 times were excluded. So, kind of a small, 3-4% of the alerts were excluded. Now we look at the override rates, and we see for the overridable alerts that the override rate was 81.3% for white patients and 82.27. So, boy, that looks pretty good, right? Well, thank you, statistics. Statistics tells us it is statistically significant difference at p.0001 using chi-square test, just comparing just these two things. But the reality is it's a 0.97, less than a 1% difference. So it really doesn't look very clinically significant. It means overall that there were 3,000 more overrides out of 1 million, close to 1 million, than we would have expected. So again, it's a pretty tiny difference. All right, but different alerts can be overridden differently. So we want to look at the individual alerts and see what's going on with them. So here's all the alerts, and I don't expect you to read all these, especially because the names are pretty cryptic, but I'll explain them in a little bit. But I just want to point out a few things before we go into more detail. So we can see these ones in red are the two alerts that actually use the GFR calculation. And if you look at the difference in rates, it's like a 9% under overrides in Black patients and a 1% higher override rate in Black patients, but they are not statistically significantly different. Okay, and then here's the one opiate. My little screen sharing thing is blocking me, so I can't see it. There we go. And there, it's 0.37% difference in the override. That's the one opiate-related alert that we have. And it's related to opiate-related creatinine clearance, but not to pain level. But nevertheless, that's an opiate-related alert. And we can see that the significance of the difference is almost 1. So really not significant. So that's good. We'll look at this a little bit more. Okay. Now, so the significant alerts of those top 12 have levels of significance below 0.05. And these are the big ones, these 4 big ones that have that, that are statistically significant. And I threw in this last one that has that's a p-value of 0.0782, because this thing is actually the biggest alert of all, and it accounts for 46% of the alerts overall. So I didn't want to just throw that one out. I wanted to take a look at that. And the others, you can see, they're all pretty small. This is the total number of alerts. I mean, 200 and so there's, 110 alerts total when we're talking about close to 1 million. So we didn't, even those are statistically significant, I didn't examine these more closely. All right, so here are the 5 that I'm going to spend particular interest on. And so there's one called allergy drug, and that has the biggest statistically significant difference. This happens when you enter an allergy into the system. You say this patient has an allergy, and they and they're already on a drug that they would be allergic to. So it's kind of like, don't order this. If you're giving this patient this allergy, you better go visit that drug order and see if you want to do something with that. So that was the most common, and it's called allergy drug, and this refers to multi medication. The next one is the height, weight, and or allergy data is needed prior to ordering. So somebody's trying to order a drug, and the system does not allow you to order the drug unless the patient's, some of the 1 or more of these height, weight, and allergy information has to be entered for the patient before you're allowed to order the drug. And of course, you can override them. You say, I don't know the height or weight, but I got to order this drug, so I'm going to do it. The next one is chest AP X-ray performed in the past 3 days. So, so this is somebody's had an anterior posterior chest X-ray, and now you're ordering another one, and the system's saying, do you really need to do this? Because they just had one. And so that's the chest AP one. This is drug-drug interaction order, which is pretty common. You order one drug and the other, and there's some interaction, tells you, what do you want to do? You want to go ahead and give it, or are you going to back off? And then this one is the drug allergy alert that we would typically think of is you go to order a drug and the system says patient has this allergy. And the override percent you can see very high, because typically these allergies get in there one way or another, and the patient goes, this patient's been taking this drug for years and he doesn't have a problem, so there's something wrong with the allergy information, or the allergic reaction is so mild and the need for the drug is so high that we're going to go ahead and give it. So that's the most popular alert. All right. So now I wanted to look at expected override rate. So if I take the override of that is occurring with white patients and applied it to black patients, I would get an expected number of overrides for those black patients. And so here I see a bunch of these alerts, and they're numbered they're in order of frequency. There's my 2 GFR alerts, and you can see that the number of expected overrides is really, I mean, you can see it, but it's pretty small. And the scale, when you look at the scale of this, it's 0 to 700. So this is a pretty small scale. There is the opiate alert, also, pretty infrequent alert. And again, there's just no discernible difference there. There is this difference here, in alert number 3. And so in fact, these green arrows are showing you where there are differences that are statistically significant, but these, again, pretty small. This one you go, maybe we should look at that. And then up here, again, it's a little hard to see because it's at the end, but there's a disparity there, and you say, okay, those are statistically significant. All right, but when we change the scale now to 0 to 6,000, a lot of this stuff kind of dropped 3, and alert 3 and alert 6, they really drop down to the point where you almost don't notice them. Now we have some others. There are some more statistically significant ones, and this one, number 2, looks pretty, worth looking at, and we will look at that one. And then number 9, also up here, is one where there's this disparity. But again, we're on the scale of 0 to 6,000. When we go to a scale of, these are the ones we're going to study, the blue circles. When we go to the scale of 140,000, now again, these things are just disappear because they're so infrequent. But the ones here circled are the ones we're going to look at reasons for. And again, a statistically significant one. Number 13, that one up here, does not have a statistically, or I would say clinically significant difference, but let's take a look. Okay, so these are each alert by itself. This is the allergy. You're entering an allergy. The patient is already on the drug. And there's only 3 reasons that were different in any major way. So sometimes people just look at the note and they're looking at the alert and they go, oh, I was just looking at the chart, I'm not going to do anything, and they just turn it off, they skip it. Sometimes they're saying that, oh, I know about this interaction and I'll be careful, or the patient really needs this, I'm going to be careful. And this is happening slightly less for Black patients than white patients, but pretty small numbers. Still, maybe that's something that we would want to look into more. Maybe we want to look, is it particular providers that do this? It could be a small number. This is a relatively small number of alerts, small number of occurrences. So when we're looking at 3% difference of 4,000, that's 120 a year, something like that. So these are really small. Okay. On this one, we have, this is the, where you have to enter allergy, height, or weight. And we can see, again, there's 2 differences. There's the treatment plan requirement is one, and disagree with recommendation. So they disagreed with the recommendation more for whites than Blacks. And again, there is a little difference here, but this is 200 or 310 alerts a year. So it's not a lot of alerts in the grand scheme of things. Here's that chest alert one. There's only one reason for override, which is I disagree with the recommendation. So of course, there's no difference in the reasons. And then we've got these 2 other ones. Here's the drug-drug interaction one. And when you look at the differences, they're all less than a 1% difference. So really, they're really indistinguishable populations. And here again, this is the drug allergy, the really common one. And again, the reasons are just, they're different. It's not like they're chosen randomly. They're very different, weighted to one end of this list, but they're weighted irrespective of race. So that's interesting. So my conclusions from this study are that the difference in override rates, while statistically significant, are in some cases really, to me, appear clinically, should say insignificant, appear clinically insignificant. And of course, that's my bias, I suppose. Maybe somebody else would go, no, those are significant. Maybe they really are significant. And maybe this is a Freudian slip here, I don't know. But I didn't intend to say that they were clinically insignificant. And I think hopefully you'll agree after looking at the data. Where the difference rates appear, the reasons underlying them don't suggest that people are thinking about these patients differently, that they're using the same rationale for overrides, just sometimes maybe a little more for one race than the other. But they're not, it's not like they were randomly distributed and then suddenly you see it pop up. It really is, they tend to say certain things and irrespective of race. Also, no evidence that supports the disparity due to GFR estimation. So that New England Journal paper that said maybe we should take it out. I'm not feeling like we need to do that. And also that there's no evidence to support disparity based on opiate pain preconceptions. So, I think we did pretty good. This is UAB. What about other places? I've actually asked at a few other places, can you do this? It turns out their racial data in other hospitals isn't as good as ours, at least the ones I asked. So they would actually have a hard time doing this study. But you could certainly do it with random, take random data and track down the races of people some other way. So the study could be reproduced. It's really easy to reproduce here or at any site where there's good data and you have one of these warehouses like I2B2. Okay, so that was looking at a broad spectrum of where problems might exist and things like resource allocation, performance of a guideline, and performance of alerts and reminders and so on. So now, where do we go from here? So I've done a little anti-racist informatics research. Great, where is this gonna lead me or what else could I be working on? Okay, so I think the way to attack this is to look for disparities related to information systems that might suggest systemic racism. Could be due to unconscious or hopefully not conscious bias, but the disparity is a marker. And looking for that disparity then could lead you to look for other things. But what do we measure? What are we going to try to measure? What's the in this case outcomes? Do we look at length of stay? Do we look at dosages of drugs? There's a lot of quantitative things we can look at, and of course we should look at qualitative things as well. Correlation is easy. It's easy. It would be very easy to say, aha, people that get this drug are getting it more often because they're black and white, but maybe it's because there's an underlying condition. Maybe it's a drug used for sickle cell disease, or it's a drug used for cystic fibrosis. And so of course it's going to be used in a disparate way related to race, but that's appropriate. So we have to think about causation, and that's going to be trickier, especially when you're trying to figure out what people's motivations are for using systems in a certain way. So we can also control for racism when we're evaluating system behavior. So imagine that we present an imaginary case to somebody who's using a system, and we say, oh, this is this patient, they come in, they have this and this and this, and now you're supposed to use the system, to make a decision or read about the patient or write a note or whatever that system does, and you deliberately vary the race of the patient, or you vary information about the patient that allows the user to infer the race. Now, I don't know of any studies that have been done with healthcare, but they've done this with things like people reviewing applications for mortgages or applications for renting apartments. And that they'll do, for instance, they'll use a name that looks very white or a name that looks very black, and they'll find that people will respond differently to the same exact information on an application form. So I think we could do that in our systems to see if they're behaving differently for things like that. All right, so we look for our disparities, and then what do we do? Well, we can also develop systems that help us promote anti-racism. By that I mean not just simply behaving in a race-blind way, but actually looking at problems in society that affect patients' health, and looking at how we can build systems that can reverse that. So first thing we have to do is collect data. We need to detect disparities in racist activity that are affecting our patients' lives. And for that, I want to turn to a little case study. I won't give you all the details of the case. I was seeing a patient in the Whitaker Clinic with the house staff, and the patient had a medical problem, and I went in to just kind of say, oh, I want to examine XYZ just to look at this problem. And I was talking to the patient, and I don't remember how it came up, but the patient incidentally mentioned to me an anecdote about how he was stopped by the police and he was physically abused. I think he said he had something on his phone, but his phone broke because the police broke his phone or something like that. Now I'm only hearing one side of the story. And I did my training and a lot of my medical practice in New York City, in Manhattan, and a lot of it in Greenwich Village and the Bowery. And so I heard a lot about physical abuse of people by the police and of the police by other people. So I knew there's a lot of sides to the story. I knew that this happened a lot. What stuck in my mind, though, was the matter of fact way he described what happened to him. And that really disturbed me, because he said, it would be like I said, oh, I got pulled over by the police and they gave me a ticket for speeding. He was like, oh, I got pulled over by the police and they beat me up. And I just was incensed by this. But despite that, it didn't occur to me at the time to modify the resident's note to include it in the chart. It just, because it was part of a different conversation and it wasn't related to the immediate problem of the patients that we were dealing with the patient. And I wasn't writing the note, and I should have gone in and made a change in the note. But it wasn't, I was thinking in, patient care mode, teaching mode. I wasn't thinking in anti-racist mode, which is a big problem for me and maybe a lot of people. And that's the problem with anti-racism, is we have to think about it consciously, and it can get a little tiring sometimes. And even if I did put it, how would I code it? How would I put that in there so that it would make a difference? SNOMED, with its hundreds of thousands of codes and lots of codes for physical abuse, does not include a way to say physical abuse by the police. And if you look in ICD-10, which are billing system, for a billing system, the word police doesn't even appear in an entire ICD-10 anywhere. So we have to pay attention to how we would do this documentation. So those of you know me, know my research, I'm interested in designing the next generation of electronic health records for lots of reasons. And now I want to add another one, which is to include documentation of racial discrimination and violence. Okay, these are social determinants of the patient's health, and I'm not just talking about excessive use by the police on unarmed Black citizens. I'm talking about somebody who said, "Oh, I couldn't get my mortgage, so I have to stay renting in this other neighborhood where there's no grocery store and I can't get fresh vegetables. Or I have to live in an area that has high crime and I can't move out because I can't get mortgage, I can't get a rent, I can't get a better job. Whatever that is, wherever the racism is affecting their lives, it's going to affect their health. It's also a public health problem. And we need to understand that by gathering records on individual patients to be able to measure this at a population level. So documentation, very important. Now there's precedence for this, okay, for documenting abuse and violence. And of course, it's related to child abuse, and it's related to things, we call it spousal abuse or elder abuse. But actually the law, I went and read the law in Alabama, and it is about abuse of vulnerable adults. And it doesn't say exactly what those are. It gives examples, but the definition will include anybody who is unable to protect themselves and is abused by another person. And that would include somebody who's in the custody of the police. Maybe they're handcuffed and they are injured in a way because they're vulnerable. And so physicians out there, we actually legally have to report this behavior. We don't think about that, but that is the law in Alabama. Okay, and of course, documenting other evidence of discrimination and racism in the records is going to be important as well. So this is part of a larger agenda for informatics research and development, but it is the redesign of the EHR and how do we collect that? And of course, where do we get it? Do we make our visits longer? Do we let the patients add to this? There are a lot of informatics challenges around improving documentation of what's really going on with the patient. You can read some of my papers on this, but we don't have time to get into that here. And certainly, I don't have all the answers. I'm starting to work on it. Okay, so we collect data to detect disparities. We can promote non-racist behavior. So if we detect, for instance, that somebody's making decisions that seem like a decision that somebody would make because of an underlying bias, for whatever kind of bias, we can propose to the user, hey, that decision seems like you're doing that based on a belief of some sort. Is that true? And people who, as I said, unconscious bias can be actually in contradiction to what you actually how you prefer to behave. And people will say, oh yeah, thank you. That is, I wasn't thinking about that, but you're right. I recognize that this is a bias and I didn't realize I had it, but thank you for, helping me avoid that. So that'd be a real challenge. And we also want to look at how do we develop systems that actually reverse the effects of systemic effects that we're seeing now. So that people that have health disparities because of systemic racism, how do we take extra care, take extra resources to work on reversing those effects? So lots of things that we could be doing. Okay, so in conclusion, what can we do? We have to recognize racism is a public health crisis. It's not just something that happens to people outside, it's something that happens to their health and the health of the population. We have to be alert to the impacts of bias as we develop tools and methods, and we have to be careful for those, and we have to test for them. We can't just assume that they're not there because we've checked, oh, I'm building a neural network, and it's, it's fine, it's neutral. We have to think about the data we're using for training our systems, which means understanding where those data came from, the provenance of those data, which may not be something that, say, a computer scientist is going to be thinking about. He says, give me a bunch of text and let me make my system work. Well, you need clinicians, informaticians, public health professionals, sociologists, lots of people to be able to help us understand what biases may be in those data. And then we want to create solutions for eradicating these disparities. And apply informatics to promote racial and ethnic parity. Really, that's the ultimate goal. These are big goals. We're not going to write one system that does everything, but we can chip away at these, I believe, if we work together. Okay, and so what's the goal? The equitable distribution of health expenditures. Be careful, equitable might not really be equitable. Something's like, I'm giving everybody the same amount of money. It doesn't necessarily mean that it's equitable, because you may have a bias in how you're distributing it, or you may not recognize that there's a greater need in some population than another. So equitable distribution of health expenditures based on what? Based on need, or based on, gee, these hospitals spend more money, so they must have more expenditures. These are the kinds of things that are really tricky to figure out. How about improving quality adjusted life years? That sounds like a really, typical one, right? Well, when you have a population that has a shorter lifespan, okay, then you're already saying that your maximum number of lives that you're going to give this person is different than the maximum number of lives you're giving somebody else. When somebody has a lower income and they have more health problems and they have more, they live in an environment that is detrimental to their health, higher crime, and so on, their quality of life is not going to be equivalent to the quality of somebody who doesn't have those impediments. So quality adjusted life years also becomes tricky. So there are still lots of challenges here. All right, I want to point you to something that I really got a lot out of. It's a podcast by Dr. Kevin Johnson, who is the chair of Biomedical Informatics at Vanderbilt University. And it's a roundtable on informatics and anti-Black racism, what we need to do. And a lot of the topics that I talked about here were covered in that podcast and also through conversations with him and others. So I don't have, the URL is long and confusing, but if you just put podcast Kevin Johnson racism, you'll get right to it. And then I have, for sharing the slides, I have a number of links here. I guess I could probably put the podcast link in here. And finally, I want to thank people that helped me in this journey to understand how I might pursue anti-racism in informatics. Some of them I think are on the call. It'd be nice if all of them are on the call. Some of them here at UAB, some of them remote, and a diverse bunch. So thank you very much. And I see, I guess I have about 6 minutes for questions. And I think I can stay on longer if need be. So Amy, how do we run the questions? We don't just open up the microphone for 44 people, do we?
We have done that before, actually, and we sort of recognize everybody. And if people can be respectful about that, we could have people chat their questions. There has been a very
there's a chat. Let me go through the chat.
Yeah, there's been a lively discussion going on while you've been speaking. So a lot of issues have come up. But thank you very much for a great presentation. So some of the issues that came up in there, our race is, what is race? It's a phenotype, it's a genetics, it's a social construct. That's kind of may be different. Also, about domestic.
Yeah, I'm looking at it. So race is, it's sort of like, you have a particular gene, but it doesn't define your race. There are people that have sickle cell disease that don't look Black because they got it from 2 great-great-grandparents. There are people who are of Black race, but they are included in Indian tribes because they were slaves of Indians way back when, and then they got persecuted by like everybody else, and their descendants seek reparations like everybody else in the tribe. And then the tribe says, wait a minute, you're not an Indian, you're Black. And well, how does that work? I was in the race and got treated like everybody else. So race is a very interesting phenomenon. And when we think about race in terms of health, it's really a weird construct, because what are we talking about? Are we talking about the prevalence of a disease in a particular race? Are we talking about how well a particular drug is going to work for hypertension? That's much better studied genetically. Or what about the chance that you're going to get a certain disease, stomach cancer in Japanese patients? Well, it depends. Are they Japanese American or are they Japanese Japanese? It's going to be different. And so, why we use race is a very peculiar thing to begin with. It'd be great someday when we simply ignore these things. And that's what Kevin said. Of course, Kevin's always way ahead of me on this sort of stuff, and he may have some advantages in that. Let's see, documenting brutality isn't new. Implication protections need to be provided. So let's see, anything that I can answer, because I'm not an expert on racism and race. I'm an expert on informatics and trying to figure out how to use it. Are the diagrams treat different because of the race or because, I'm not sure if that's a question for me.
It should be diagnoses and treatment, not diagram.
Diagnosis and treatment different because of the race or because of genotype? Yeah, okay. Well, it looks like Umberto and Kevin need to have a podcast to talk about this stuff, and when we do, we'll promote it. But if anybody has questions for me, I'm very happy to. We're all friendly here, so if somebody wants to just chime in on their microphone, let's see how that works.
Yeah, Jen, this
So-
is Kevin. I have a question for you.
Go
First
ahead.
of all, I assume you can hear me okay, right?
Yes, I can.
Great,
Thank
yeah.
you. I can
So
see.
congratulations. You've done an amazing amount of work in a little bit of time. And I have to say, I wish I could figure out how, while I was listening to a podcast, I could do a quick I2B2 download, grab alert data, and do an analysis. Or listening
Oh, I was doing one now.
if only. But the question I have for you is, you know, it's been fascinating for me to think about this comment about what people choose to document and when they choose to document it, and the extent to which that's based not only on the capabilities of the information system, but also potentially on biases with the person who's documenting. Do you think from what you've seen and what you experienced, that there is a way to balance the challenges of things like alert fatigue with a need to perhaps change behavior to improve the quality of documentation in this space?
So I haven't thought about this particular space in terms of how to improve documentation, but I have been thinking about it in general. And I think there are some general precepts that I hold to. One of them, and maybe the most important, is that the person doing the documentation has to have benefit from doing that documentation. And it has to be palpable. And the benefit could be to their patient, it could be to both of them. It has to make that person's life easier and the patient's life better through that effort of documentation. So, but directly. Now, so for instance, writing something that's going to help later, like when social workers write these big notes, it's going to help the next social worker. They're not as enthusiastic about it. But when somebody puts in orders for medications and they know they can print a prescription every time that patient comes in, and that was my experience at Columbia, that people used the medication ordering system. It went through the roof once we added a print prescription button because there was a perceived benefit. So in the re-engineered electronic health record, that record is going to be more of an assistant. And so if there are things that people can put in that will allow the system to act smarter, and the user can perceive that. And the system says, oh, you did this and this and this, and so I'm going to do these other things for you because that's what you were going to do, right? And they go, yeah, thanks, you read my mind. That we need to do that kind of stuff. How we do that with the racial piece is probably going to have to fit into a bigger context of more, all kinds of social things that we don't collect about patients that we need to. And again, haven't figured out what's the payback. The immediate payback has to be more than just, hey, you did a good job writing your note. Because right now people write their notes, I got to get this note done before 5 p.m. or I turn into a pumpkin, or I'll write my notes over the weekend, when I have a little breathing time. So right now the note is just a chore. The documentation's a chore. So we got to figure that out. And, we need some good clinical informaticians, and it's going to be more than just me and my friends here at UAB. We could certainly look at collaborating with you guys up the road on that.
Thank you.
Jim?
Yeah. These are all my ringers. Yeah, go ahead, Anita.
Kevin's question. For instance, I really thought it was very interesting in your presentation, and I was related that to a work that we do at the American Academy of Pediatrics with the Policy for Partnership Implementation Group. It's a bunch of pediatric informaticians that actually review the clinical guidelines before they are published, all the ones from the American Academy of Pediatrics. So thinking about that, we never really paid attention to this, right? As we review guidelines, they are done by experts and evidence-based guidelines at the American Academy of Pediatrics. So how do we make sure then that we can look into this, take the considerations that you put here so that when we publish those guidelines, we make sure that the description of them in the manuscript that they are all published, right, or in the documentation, and address the implementation issues at the same time. It's a hard question, and it may not be completely well formed, but I was just trying to understand how we take this and now we apply this, right? Sort of what Kevin was saying, how do we make sure about the documentation? How do we make sure of that implementation of the guidelines that are then reviewed by groups like American Academy of Pediatrics, and there are others, this is just one example, to make sure the implementation gets done properly?
Well, so let me give you a half-formed answer to your half-formed question. You know, one thing I think about is, you know, sometimes simply making, bringing bias to people's conscious attention is sufficient to make them behave differently. To say, you know, you're doing that because of this. I remember, I won't name names, but somebody was planning to vote in an election about 12 years ago. And she said, oh, I'm not voting for him because of blah, blah, blah. And I said, well, you know, you're entitled to that opinion, but you have to recognize that that's a racist opinion. And she said, oh, you're right. I didn't think about that. And she voted the other way. So thank you, Obama. Or you're welcome, Obama. So, you know, sometimes we can make that on the checklist, maybe. Where's race playing a role in this? Or where is race playing a role in the data that we used to come to these conclusions, right? And so that may be a, you know, something we have to add to the process of guideline development, but we can make it formal. And then people will maybe be more cognizant of the possibility of this. We need better data. The fact that we're using data sets where race is not accurately captured means that the racial disparities in there are slipping through and affecting the outcome. And again, unconscious, we don't know that's in there. And that's the problem with these racial, you know, these machine learning algorithms that are using population data without appropriate race data. And of course, you know, what's a person's race? I mean, we have, even here, we have a lot of people, you know, several percent that say, I'm not going to tell you, or it's multiple races, or, you know, and it's, you know, and again, it's such a strange construct, you know, what race is Barack Obama, you know, a white parent and a black parent, you know, I guess we would say the test is, is somebody going to treat you badly because of whatever your perceived race is? That's, in that case, is really a test. If we're looking at, is your risk of this disease higher because of your race? Well, then, you know, then that would be a different question. But I think part of the answer is, in creating these guidelines, the evidence we use, we have to vet that and understand where the data come from.
Right, thank you, John.
I see Hope has turned on her camera.
Yeah. Hi, Jim. Hi, everybody. One of the challenges that we faced as chaplains in the EHR is that the data is entered by patient access. And so, for example, sometimes patient access will assume by the looks of somebody that they're Hispanic, or assume that they're Catholic because they're Hispanic. So, I mean, there's a lot of challenges. So you send the priest to a room and the people are like, no, we're not Catholic. We don't, we might be Hispanic, but we're Jehovah's Witness. You know what I mean? So race and religion and gender in the EHR, at one of the social worker conferences, they mentioned that we need to have alerts in the system because there are some who do not want to be called. They may look like they're female, but they don't want to be called by the female name that's in the chart.
Yep. And it's you know, convincing people that are charged with doing the recording are, you know, maybe not always recognizing the importance of doing so. And so, oh, come on. You know, I can say he, she, you know, what's the problem? And may not be aware of that. So there's a lot of educational aspects. You know, I thought I was white, but in Alabama, it turns out I'm Italian. And wow. Although I'm only half Italian, I haven't had an Italian name. And there more than once, patients have sort of implied that they were less than happy with getting an Italian doctor to take care of them, and these were white patients. At least I think they were white. They looked white. And they were reported white. So although I'm not claiming any great harm has come to me through, you know, discrimination, at least to get a little flavor for what that's like and how it catches you off guard. I can't imagine what it's like to be that constantly have to think that way. But that's the kind of thing I'm railing about. But I don't want to get into my personal journey here. Other questions about informatics?
This is Amy. I have a quick, it's more of a comment than a question, which is the difference. It was teasing out the any kind of inherent systemic racism in informatics, like you mentioned with the machine learning, versus that it's just magnifying the systemic racism in the people. So that the study that you did, maybe that it'll be different depending on where you do it, depending on the, whether, how much systemic racism might be in a given population.
I'm sorry, I didn't catch, could you say the question again? I lost, I was listening to the question.
That the teasing out whether there's inherent systemic bias in systemic racism in the informatics, let's just say in the technology or the EHR or the alerts or whatever, as opposed to that the informatics technology is only magnifying the systemic racism in the people that are there. So maybe if you do that study somewhere else, that one you showed with
Right.
the alerts, that it might be different in a different population.
Right. Well, it's certainly a difficult task. So first of all, if I just looked at the overall override rate, when I first did this and I looked at the override rate, I said, oh, good, it's the same. But then I said, wait a minute, some alerts are overridden by more for one way, and more for a different reason. And then I broke it down into the individual things and actually found a few places where, yeah, maybe there's a place I should do this. And maybe I need to now look at individual providers, because the individual provider is really maybe the unit of measurement here, right? That if there is a bias on the part of the provider, they're going to tend to be biased for all, in all their alert responses. And I can.
All right, everyone. I think Jim had an issue with his internet connection, and we're over time too. So thank you very much for attending, and look forward to seeing you at the next Power Talk on next Friday. Have a happy weekend.